Hello, hello, everybody. Hello, happy Friday. So good to see everyone. We'll give you all a minute to get connected. I love seeing all of your faces. What a good way to start off the weekend. My name is Anissa Mitchell, and I'm with PMD Alliance. I'm going to welcome you today to our Lunch with Docs. For those of you on the West Coast, this is lunchtime. For those of us on the East Coast, maybe grab a little afternoon snack and settle in for our program. I want to go over a bit of housekeeping before we get started. Open up your chat box. If this is a new thing for you and you're unique in just using Zoom, it's just at the bottom of your screen if you're on a computer. Hover over at the bottom where the chat box is and open that up. And already Ken, thank you, has done the shout out. I love to find out where people are joining us from. So give us a shout out. Tell us where you're from. So hello to Ken from Oregon. We got, Australia is joining us again. Karen from Canberra. I love it. Love seeing where everyone is from. So we are actually still waiting for Dr. Bullen. I just got a call from her. She was in clinic, so she's going to be joining us momentarily. She's coming, but she just got tied up with the patients she was seeing. So in the meantime, this is a good opportunity to find out where everyone is joining us from. And I would love also for you to kind of highlight maybe some of the top questions that you might have. So today's topic is going over non-motor symptoms, just an overview of non-motor symptoms. And, we talk a lot about motor symptoms and treatments for those. A lot of times those treatments can help with some of our non-motor symptoms, but they don't always. And so today we're focusing on that subject because there's actually more non-motor symptoms than there are motor symptoms. And those are the ones that tend to have a lot of correlation to a person's quality of life. And if you're the care partner, you are also impacted by that. So these can range from mood issues like depression or anxiety to having hallucinations and delusions to problems with your constipation or gut. It can be things like dizziness, low blood pressure, things like that. So if you have any pressing questions and things that you're hoping that she's going to cover, then I can let her know when she gets in here and we can go through that. So sleep problems is definitely one of the main ones. And I do believe she does cover sleep problems in this particular presentation. She actually did this presentation at an in-person event that I saw her, and I'm like, you know what, this would be a really good online program. So yes, and hallucinations, whether they're a sign of dementia. So these are some really good questions. Keep them in and coming in. We've got Boston, we have Texas, Nebraska, New York, Arizona, Orlando. Hey, I'm in Orlando. Nice to see another Orlando person. Cleveland, Philadelphia, Massachusetts. I love seeing where you're all from. Oh, Alaska, 34 degrees and snowing. That's amazing. And it's 80 some degrees and sunny in Florida where I'm at. So vastly different parts of the country and different weather that we're experiencing. Rhode Island, Rocky Gap, Virginia. That's awesome. So where else are we coming from? Jacksonville, another Florida person, another Oregon person in rural South Oregon. We've got Lake Erie, Ohio. All right, New Haven, Connecticut. All right. So I'm so glad that you guys are telling us where you are from. We'd like to see that. Sometimes we'll kind of pull a report and say, hey, what states have been represented? And so it's really cool to see that. And Southern California wants to know about dementia and anxiety and apathy. And we've got a question about digestive issues and iron deficiency and Parkinson's. That's a good one. I've heard of vitamin D issues and Parkinson's. That's a good one. Dizziness and shortness of breath. So great. These are really good. And Julie, have we seen Dr. Bolin yet? Nope. All right. Well, we're just going to hold tight. I did actually speak with her on the phone, so I do know she's coming. So, we give them a bit of grace because they are donating their time and their expertise, and they often are squeezing us in literally in the middle of their clinic days. So I appreciate that you're being patient with us and that she is doing her best to get on here. And someone wants to know, do you have personal experience with PD? I don't know if you're asking me specifically, or George, I think, was asking that, or if that was just a general question. So skin problems, that's a good one. All right. And yes, actually, I do have personal experience with PD. My mom had Parkinson's, and she actually was diagnosed after I started working in Parkinson's, which I've been working in for going on 12 years now. So I've had it both on the professional side and on the personal side. So yeah, and it's means a lot to me to work with those who are dealing with something that my mom actually experienced. So yes. All right. Well, nausea, that's another good one. And not able to sleep through the night. So I think that's probably a very common issue. Raise your hand if sleeping through the night is a problem. Yes, and I know that that can be a problem for those who are getting older. Just in general, I notice that I'm waking up more often than I used to. And then sometimes, like last night, it was hard to get back to sleep. And then, yes, George, he's the care partner. If your loved one's not sleeping, you're often not sleeping. So fragmented sleep is a big issue. How about vivid dreams? Anybody experience vivid dreams? Yep, Jackie's saying yes. They can get pretty intense. Now, especially if you experience like REM sleep behavior disorder, where you're acting out your dreams, that can get pretty intense. And I think the bed partners probably experience that firsthand, maybe even more than you might. Oh, and somebody said their loved one curses out loud and shakes their legs. So, yep. So that could be other sleep issues like restless leg syndrome can be something that you might experience, or at night periodic limb movement syndrome. So yeah, that can be very disruptive of sleep for the bed partner and for the person experiencing it. And dreams leaving you feeling exhausted can be very difficult. So then you have what problems during the day? Then you're tired during the day. Who has a hard time not wanting to take a nap during the day after having a rough night? Yeah, Arta's saying yes. Jackie's saying yes. Seeing Judy saying yes. Yep. So, and are there signs of dementia? The sleep that's a good question for Dr. Boland. I don't know if there's the correlation between REM sleep behavior disorder and dementia. I think that is a good question for her. And I know she's going to cover sleep. Headaches, that's a good one. Yeah, headaches. Anybody else experience headaches? Yes, I see some hands up. Susan is saying yes, and I can't see everybody. So if you're waving and I'm not shouting out your name, it's because we have quite a few screens. I have 5 versions of the screen, so I can't see everyone. But, and who knows, that could be a variety of different things, right? So weight gain and behavioral changes. Who maybe initially gained weight and then maybe started experiencing some weight loss? Anybody have that experience? Okay, I'm seeing maybe a couple nods to that. And behavioral changes, so that can be depression, anxiety. It can also be apathy too. So I believe Dr. Bullen is on. Are you there, Dr. Bullen? Okay, let me.
Yes, hi, how are you?
Hi, Good afternoon.
Good afternoon. So great to see all you guys.
So
So
good
happy
to
to
see
be
you.
here.
Well, I'm so glad that you made it. I told everybody you were very busy in clinic, and we've been just talking about all the different things from a non-motor perspective that they're interested in hearing about and learning about, and some questions that they have and where they're from. And we have them from Alaska, from Australia. So we've got a great crowd today. And for those of you who don't know who Dr. Bullen is, she is a movement disorder specialist at Ascension Medical Group in Pensacola, Florida. And interestingly enough, before Dr. Bullen became a physician, she was a physical therapist. So she has that background as well as being a movement disorder specialist. So I am going to hand this over to you, Dr. Bolin, and let you take it away.
Thank you. How is everybody this afternoon? I hope everybody's doing good. Give me just 1 second. I'm going to step away from my desk and close my door because I have a noisy hallway and I didn't close it. So 1 second. Okay, I am back. Can everyone hear me okay? Can you hear me okay, Anissa? Great, good. So glad. Well, I'm going to see if I can share some slides, and let's see if I can make magic happen. Some days I'm good at it, some days not so good. So we'll see what I can do. So just bear with me and Anissa for 1 second, please.
That's no problem. You take your time. And Julie's here to help you. I'm not that tech savvy. Yeah, we are getting a lot of really good questions, Dr. Bolin. And I know you're going to cover some of this stuff. So hopefully some of those will be answered.
Do I have authorization to share my screen? Yes, I do. I see it now. Is everyone able to see the screen now? Yes? Are we good, Anissa?
You are good to go.
All right, we made magic happen. All right. So what we're going to talk about is what is Parkinson's, what does it look like, a little bit about the pathophysiology, the motor symptoms, the non-motor. And then we're going to really focus our talk on non-motor, a little bit about wearing off and dose failure, and the different treatment options. So what is it? And this part we're going to move through quickly because everybody knows what this is. So it's a progressive neurodegenerative disorder. It's the second most common disorder. Alzheimer's is the first. And it's characterized by not enough dopamine. And it's because there's a problem in the substantia nigra, right? So it affects about 3% of people over 65, up to 5% of people over 85. We know that as you get older, your risk increases. And it's more common in men than women, right? So the most common neurologic neurodegenerative disorder is Alzheimer's disease, and that's more common in women. And Parkinson's is more common in men. But the incidence is increasing in both men and women. So the pathophysiology, if you're looking at, we call these, some people call them Mickey Mouse ears, right? They kind of look a little bit like Mickey Mouse ears. That's in your brainstem. And if you look at that yellow arrow, you're going to see that very dark black area. That's where the dopamine is. And if you look at the blue arrow, that's a Parkinson's brain, and there's not as much dopamine. So what does PD look like? Well, we all know these people, right? And these people have Parkinson's. So the motor symptoms, I talk about this all day, every day in my clinic, right? I talk about the 3 S's: slowness, stiffness, shakiness, 3 S's, right? As doctors like to use fancy words: bradykinesia, rigidity, tremor. And then there's a 4th criteria, which is loss of postural reflexes. So there's 4 things. In order to have the description of yourself of Parkinsonism, you must have 2 of the 4. One of them must be the slowness or the bradykinesia. So you need to then have slowness and stiffness, or slowness and shakiness, or slowness and loss of postural reflexes. You don't have to have all 4 to have what's called Parkinsonism. Then there's many causes of Parkinsonism. Parkinson's disease is one of those many causes. So what are the non-motor symptoms? That's what we're going to talk about today. There's the neuropsych problems, the autonomic problems, problems with sleep and wakefulness, a lot of sensory issues. So this is a paper that was written recently overviewing all of these things. So in that paper, they talked about some very important things. They talked about depression in the neuropsychiatric section of non-motor symptoms, depression, anxiety, apathy, which means you just don't care and you kind of get to that point, psychosis, impulse control problems, dementia, cognitive problems, problems with, either MCI. Does everyone know what MCI means? Anissa, have people kind of talked about that before?
They have, but there may be people out there that don't know what that means.
Okay, so that means that you don't have dementia, but you just have some problems with memory, but you're still able to perform all of your activities of independent living independently by yourself, whereas somebody with dementia is not able to always do that. So that kind of is where we separate things out practically. Now there's some other specific criteria that physicians and neuropsychologists use, but that's kind of the general principle. And then problems with executive function. So that's planning, and that's the big one, is kind of planning, multitasking, those kinds of things. Anhedonia, hallucinations, and delusions.
And you might want to explain anhedonia, because I'm not sure everybody understands what that term means either.
Yeah, that's kind of an indifference, more than an apathy of you identifying that you don't care. Anhedonia is just kind of an indifference, I guess would be the easiest. Oops, going the wrong way. So depression. Depression is very, very common in Parkinson's disease. And I would say at some point in the disease course, most patients are going to develop a minor depression. And I think that mean number, as research studies continue to focus on non-motor symptoms in Parkinson's disease, will definitely increase. And I think it'll be closer to that 50 to 70% number. So how do we treat depression in Parkinson's disease? So there's some different ways to do it. We can use dopamine, right? We all know that in layman's terms, we say dopamine's an upper, right? So what does that mean? Well, when you exercise, you release dopamine and you feel better. So in the research studies, pramipexole showed to be the most efficacious dopamine therapy if we were going to use that to help with depression. Then tricyclics are likely some of the most efficacious, again, in the research studies. And that's things like nortriptyline or disopramine. And unfortunately, a lot of the SSRIs, which is things we commonly use, in the research studies didn't show a lot of evidence, but clinically and practically we use those a lot because they're well tolerated. We can easily prescribe them. And Effexor is a really good choice. We like that choice a lot. And some of these alternative therapies haven't shown any evidence one way or the other, really.
Dr. Bolin, I don't know if you mind having questions throughout or if you want to wait, but someone wanted to know if you could explain the difference between depression and demoralization. And then another person wanted to know about Cymbalta and how that fits in with your treatments.
So I think when it comes to selection of antidepressants, it's very patient specific, and you can find a research study to prove anything with any of these antidepressant medicines. So what works for one patient may not work for another patient. So I think medication selection is very patient specific. And what was the other question?
Yeah,
Demoralization?
and depression. What's the
So
difference?
so the definition of demoralization, I think, varies from person to person. So what specifically was this person referring to?
Um, I think maybe because some people might not necessarily have a clinical diagnosis of depression, but that doesn't mean that they don't feel a sense of hopelessness or maybe grief of.
Oh, I see. I
Yes,
see.
but they don't fit the profile or symptoms otherwise of a clinical
Yeah.
depression.
So there's a difference between, and we're going to talk about this. I don't remember what slide it comes up, but there's a difference between um, clinical depression that's been diagnosed by a physician that is persistent most of the time, with fluctuating depression in off periods in Parkinson's disease. And I think that is something that's very, very missed a lot and people don't ask about, right? And that's why we're talking about it today. And then the third thing is, I think, situational depression, which is maybe what this person is referring to. There are some people who just have a tendency because of their biomakeup and of their biochemistry that they tend towards more depression. Some people are depressed because of their situation, right? And so then we can separate those things out. And regardless of the cause of the low mood, because that's what it all really comes down to, I think it all needs to be aggressively treated. Whether that's with pharmaceutical agents or not depends on the patient, but regardless of what type of low mood it is, it needs to be addressed aggressively with your healthcare team. Is that kind of, yeah, okay. Anxiety. Again, many Parkinson's patients experience anxiety. And again, reminding you, anxiety is a sense of breathlessness, sweating, chest discomfort, you're restless, you're kind of feeling dizzy. This can respond to dopaminergic therapy, definitely. But more severe anxiety may not respond, and we may need to actually do something different with that. This is something I just stuck in there. I have really been shifting some in my practice, actually. Anissa, and I don't know how many others around the country are doing this, but I am really starting to add as first line therapy meditation and mindfulness. And this was one example of a paper from a few years ago, but if you research Parkinson's disease and meditation or mindfulness, you'll see a bunch of research out there. And it is really beneficial for patients. I like my patients to start integrating just like a physical body exercise, integrating meditation and mindfulness into their daily regimen 5 to 6 times a week. You start with a few minutes, 2, 3, 4, 5 minutes, and you work up to a comfort level for yourself. There's a plethora of apps out there. And what I always tell people is the app that, if we have a caregiver sitting in the room, myself and the patient, and I say, the app that works for the patient may not work for the caregiver, may not work for me. But a good quality app that I've used, and I don't know if Anissa's team at PMD Alliance has recommended any kind of meditation mindfulness apps, but I know one that is quality is called Headspace. And that is an app where there's a lot of choices within the app and different things you can do within that app. And that's a quality app, but you can go to that, look and see what quality is, and perhaps find a different app that fits you. But I think this is where we start with anxiety and depression, and then we add in the pharmaceutical agents as we need them. And so what is mindfulness? it's really that mind-body connection and really connecting your mind to your body and your body to your mind. And it's thought processes that are very specific and, bringing the attention to the present moment. And I think this is all things we've talked about. Oops. So cognitive issues and dementia, we know they're pretty much universal, subtle things. Whether you go on to develop Parkinson's dementia is another issue. But bradyphrenia, that slowness of thought, things slow down, is definitely very universal. So everything from problem solving, you can't do planning, you can't organize things, you can't switch from one thing to another, have difficulty organizing things in space and, drawing a map, say, something like that. And then learning and memory and retention can be an issue as well. 30 to 40% of people will go on to develop Parkinson's dementia. So how do we treat this? In the research studies, Exelon or rivastigmine has proven to be the most successful. Practically, a lot of us will use the Aricept, but rivastigmine is what was shown in the research studies. What I like my patients to do for their cognitive exercises, so now you have 3 exercise categories I'd want you all to be doing, right? You need to be doing physical body exercise, meditation and mindfulness, which is different from cognitive exercises. So 3 groups of exercises on a regular, consistent basis. So the cognitive exercises is I want everybody to be getting up every day and orienting themselves to the date and what day it is and what they're doing that particular day. Then doing reading throughout your day, 2 areas, something that you like as a preference, whether that's fiction or fact, and kind of going through a book, and then just kind of reading different intermittent things like the current events. Brain games, those should be 1-way and 2-way brain games. And then socialization, and that's been challenging, right, since COVID hit, but I think things like PMD Alliance have really come up with great, interesting ways to have people socialize and help them in all the online activities. Azilect, that's the rasagiline, did show to help a little bit with executive function if that was an added-in medication. So I think that's something to always consider. I like to use Azilect and rasagiline. So that apathy and fatigue, that's one of the toughest things to treat in Parkinson's disease. And that's when you're just, you can't get out of bed, I think is the easiest way to say it. And this can be caused by the disease itself. It can be caused by some of the medications. The dopamine agonists are the biggest contributors to that. Or we've got to look for other causes. I can't tell you how much B12 deficiency I diagnose in my Parkinson's patients all the time. There's some conflicting data about whether levodopa lowers B12 levels. So that's not an all cause, but it's something to be aware of. So all of Parkinson's disease patients should have a B12 level checked at some point in time. But what we do know is that metformin, that diabetes medicine, does lower B12. So we need to be cognizant of that if you also have coexistent diabetes, which is very common in this country. You should have those B12 levels checked. And we know that a lot of fatigue can go along with low B12. So again, things like Exelon, rasagiline, sleep, exercise, we know it can be very important for the apathy and the fatigue. Hallucinations, these are visual. If they're auditory, then you need to be talking to your neurologist about what could be the other causes of those auditory ones. They tend to be visual. Really, honestly, in today's world, I put the clozaril and Seroquel on here, but really Nuplazid should be the medication that's prescribed if you have Parkinson's disease and psychosis. That is pimavanserin. That's the medicine for PD psychosis. And the thing to remember is, you can have a sense of a presence, you can see shadows. All of that is well within the realm of hallucinations that occur within the disease itself. What I tell my patients is we don't treat it with a medication as long as you have awareness and it's not disruptive to your daily routine. But we add in the medicine when you start to lose the awareness and when it becomes disruptive to the daily routine. The vast majority of Parkinson's patients have a sleep problem, whether that's restless legs, PLMs, REM sleep behavior disorder. We know 90 to 95% of patients who have a REM sleep behavior disorder early on in life will go on to develop some sort of synucleinopathy, and Parkinson's disease is one of those synucleinopathies. Excessive daytime sleepiness, somnolence, is a lot of times medication-induced. The dopamine agonists are the big ones, but I've seen patients fall asleep on low-dose levodopa because they simply couldn't tolerate it. Sorry, I just needed to take a drink of water. So we know circadian rhythms are disrupted, and so I like to get a lot of my patients, once they start identifying a sleep issue, on melatonin, because that really helps with circadian rhythms. Even if that's a low dose melatonin, I like to get you on that pretty early on. We know for insomnia, Nupro, the patch, can help a little bit, and we always need to consider things like the CPAP, right? If you have obstructive sleep apnea, that should also be diagnosed. For REM sleep behavior disorder, we really have two medicines, clonazepam or melatonin. So those are the two medicines we'd want to use for that. So autonomic symptoms, that can be urgency, frequency, sweating too much, sexual dysfunction, orthostatic hypotension. And these are all things that can really affect quality of life. And then the orthostatic hypotension is a biggie because that can lead to falls, that can lead to a fracture, and you can actually get, very hurt and not recover well from those. So we work very hard to prevent falls and prevent orthostasis in our Parkinson's patients. If you have any symptoms of lightheadedness, dizziness, low blood pressure when you stand up, that should be something that's monitored closely in your physician office when you go for your appointments. So the urinary problems tend to be lower urinary tract problems, and those present very early in Parkinson's disease. And again, depends on what study you read. There's a lot of different percentages that are out there, but it tends to be irritative. So that means you're going to have more of the frequency and the urgency and the nighttime going to the bathroom and things like that. And we think that's because of what we call detrusor overactivity. So your bladder capacity and ability to hold urine is decreased. So what do we do for that? We do bladder retraining. Depends on your given area. Some places, even physical therapists work on that, so it just depends on your area. Vesicare is a good one to use, and I don't like a lot of my patients to use those antimuscarinics because that can cause cognitive issues. But, sometimes we'll use that oxybutynin. Mebitric is another newer medicine that's really good, and people like that a lot. And then we know for nocturia, again, if we restore those circadian rhythms, sometimes that will help, and I like the melatonin. Botox is good, and that's done by the urologists. And we don't know what role dopamine plays with urinary problems.
Can I interrupt you really quick? Just because I know that this topic comes up a lot in relation to UTIs. But that's when somebody might experience some delirium related to it, but they may not appear to have symptoms. So the typical pain with urination isn't there. Can you just speak a minute on that?
Yes, I can't tell you how many UTIs I've treated in the past 2 weeks. We get urines in this clinic all the time. Yes, you have to. And I think every single one of my ladies and my men who I've treated said they had no symptoms and didn't know why I was getting the urine. And then we called them back a couple days later and prescribed an antibiotic. So yes, it's a very important thing. Anytime somebody has worsening cognition, we always get a urine. Is that the question you were asking, Anissa?
Yeah, it is, because I've had several care partners through the years see a change in their loved one's status, but they didn't seem to have any symptoms of a UTI, and did end up getting a urinalysis done and found that they actually did in fact have one. And it sometimes can end up in hospital because of a rapid decline of mental state. So it's good.
Oh, all of the time. All of the time. Yes, I can't tell you how many of my partners, I don't see patients in the hospital anymore, but how many of my partners get are asked to go see a patient in the hospital because of delirium, and they check a urine and they have a horrible UTI. And at that point, because they're hospitalized and they're so delirious, we have to give them IV antibiotics. So if you start to slip and there's not a reason, meaning cognitively slip, I always want to get a urine.
And that's different than somebody who is experiencing psychosis, because they can have hallucinations, as I understand it, if they get an extreme delirium. So the thing that sets it apart is the rapid onset.
Yes. Exactly. Yep.
All right. And then one more question related to the urinary issue was, someone asked about Botox for urinary urge issues. Is that what you were referencing when you said the urologist? Okay.
Yes. Yep. Exactly. Neurologists do a lot of Botox, so there can be confusion with who does the Botox to the bladder, and it's the urologist who would do that for you.
Fabulous. Thank you.
Yep. Okay, so for orthostatic hypotension, I like Northera. Northera's generic name is droxidopa. When I made this slide, we didn't have access to a generic. We now do. However, I have seen with the generic not as good control as I have with the brand name. Food for thought. Sometimes insurance will make you use the generic. That's okay, you try it, and if it works for you, all the better. If it doesn't, I want my patients to know the Northera brand name still does exist. And we will try the droxidopa first. Midodrine and Florinef, I feel in Parkinson's patients is something we're going to use as a starter agent and eventually move to the Northera for long term. Or we're going to use temporary because there's something else going on causing them to have their blood pressure lower, and we're going to fix whatever that other thing is and then pull them off of that. But I don't like my patients to be on Florinef or Midodrine for years and years and years. If it's years and years and years, then we need to switch you to Northera. Some of the non-medication interventions are increase your fluids. That's where I always start, 48 to 64 ounces a day. Salt tabs, that gets tough, doesn't always work as well. I like the high sodium drinks. They make some lovely drinks out there today. In today's world, all these sports drinks. So what I tell my patients is you go look on the back of a bottle and just find something that's very high sodium and that you like the taste of, that doesn't have sugar, and that works well. Here in Florida, compression stockings are always a challenge, but that's an option as well. GI problems, constipation all day, every day, right? That's inherent to the disease process. So I like to get that under control early. Step 1 is the fluids. Step 2 is a high fiber diet. My little trick for high fiber is you look up online and you find a high fiber food list, and then you kind of look and see one item you want for breakfast, one item for dinner, one item for lunch. I find patients who put one high fiber food item with each meal do better long term rather than saying, oh, I'm going to have a big, huge salad for dinner. If you have a little bit of high fiber sprinkled throughout your day, it tends to work a lot better. If we have adequate fluids, 48 to 64 ounces, if we have high fiber a little bit with every meal, and that's still not working, then that's when I move to Miralax, and that's the next step. Some of these other problems that can happen in Parkinson's disease, things like nausea and vomiting, drooling, will loss of taste, and that has to do with sense of smell, right? You can get the dysphagia or the choking or the reflux. So here are some of the different treatments. We talked a little bit about those. Magnesium works great. I like magnesium calm because that also helps with a little bit of the anxiety and Parkinson's we see. Amatiza works great. Linzess is another newer one out there that works well. Smooth Move Tea can work well as well. So these are all some of the different ways you can help with constipation. Sensory symptoms. Visual changes. I like my patients to all have an ophthalmologist and get annual screenings, or just have that relationship established and the ophthalmologist say, you know, how often they need to come in to be screened to make sure there's nothing going on there. And I find pain, for the vast majority of people, are related to rigidity and the muscle stiffness. So if we can get that rigidity under control, then that's very helpful. And I guess I should say rigidity and dystonia, right? So it's under treatment or wearing off, which could potentially be under treatment as well, right? So if we're just under treating the rigidity, or we're getting wearing off and a wearing off dystonia, which is when, you know, your hand may curl like this, or your foot gets stiff and stuck and turns in and down. That can be incredibly painful, and that is some of the most painful things associated with Parkinson's. The paresthesia is just that numbness. That can not necessarily be a neuropathy, or it doesn't have to be coming from your neck or your back. It can just be related to good old Parkinson's disease. And then obviously, you know, the sense of smell and all of the things related to that occurs very early on in the disease. So pain. This was a study that was done in 2017, and look at those numbers. You know, 90% of people are going to have some sort of discomfort related to the Parkinson's disease itself. And how much did the pain impair their life? Almost half of the patients had that. And I think that this paper shows that patients and physicians need to collaborate together, right? Because unless you tell me what's going on, I can't help you fix this problem, right? And unless the physician is aware that it's a problem, they don't know to ask. So I think this is a two-way street with the pain and really trying to help patients get that under control. There is a component also, besides the muscle stiffness and besides the dystonia, of essential pain. And this is, we believe, directly driven by the Parkinson's disease process and the loss of dopamine and not making adequate amounts of dopamine. And, you know, because dopamine has to do with reward pathways, and is your reward pathway modulating your pain pathways, and that's the general principle here. We talked already about dystonic pain and akathisia. That's just an uncomfortable feeling. You just, you know, feel like you gotta move and you can't sit still, right? So that's what happens in restless leg syndrome a lot. And a lot of patients have restless leg syndrome. And I can't tell you, again, Anissa and the group here, it's just like the B12 thing. How many patients I've recently tested whose restless leg is out of control and their iron levels are too low. And we know that's one of the big triggers. So again, if you can't get those restless legs under control, you know, you want your physician to be testing that iron level. And there's a special kind of iron that correlates to the restless leg problem. It's called ferritin. And that number I like to be around 50, and that's my magic number. And remember, if you're going to replace iron, it causes constipation, so you're creating a double whammy for yourself, right? Because you have constipation related to your disease, and now you're taking a medicine, even though it's over the counter, that causes constipation. That's the first thing. The second thing is you get better absorption, so could potentially have a lower dose of iron if you take it with vitamin C. So making sure you do iron and vitamin C together, that's the optimal way to replace iron.
And I'm so glad that you mentioned that, because that was specifically one of the early questions while we were waiting, was whether iron deficiency is a common issue in Parkinson's.
I don't know that it's a common issue, but if you have uncomfortable restless legs that are not being well treated, that's when the trigger should be to evaluate for that, which is getting the labs.
Gotcha.
So how do we treat pain? The dopamine agonists, antidepressant medicines, anticonvulsants, things like duloxetine is a very common medicine we'll use for that. Non-steroidals, opioids, we try to avoid those, but if we need those short term, we'll use those to get pain under control. A lot of neurologists, though, now, depending on what state you live in, clinics have policies about that. So making sure patients have appropriate expectations of what they can get from what physicians. For example, in my clinic, I don't prescribe any opioids. I'm not allowed to prescribe any opioids, and I would have to refer you to pain management if it came to that point. So I'm going to work very hard to use all of the other tricks in my bag to avoid doing that. And then Botox, that's more for some of the dystonias, things like cervical dystonia and things like that. I love this next list of treatments: massage, acupuncture, exercise, yoga. Those are really the areas we want to start with a lot of times. I have absolutely, this is a sensitive topic, and I don't want to get too far one direction on this topic, and I don't know that I want to even answer a bunch of questions about it today, Anissa, but with cannabis, I'm not opposed to it, but since it has become a medical intervention within the state of Florida, and many of my Parkinson's patients are on it, I have not seen huge success for treating the Parkinson's symptoms thus far in the vast majority of my patients. I think it has to be very, very well selected, and there is a certain patient population that will receive the benefit from that, but I don't know that it's everything we had hoped it to be in the vast majority of patients. And I know there have been some talks on cannabis with PMD Alliance, and I think those physicians have helped to identify who those patients should be and when to use that medication and how to use that medication. And I think those are the things you want to refer to and see if you fit those pictures and to use that medicine. And even though it's easily accessible, relatively, really, at the end of the day, I think you should definitely consult with your movement disorder specialist to see if it's the appropriate medication for you. Spinal cord stimulation, that's for our chronic back pain patients who really can't get it under control with anything else. Electrotherapy, the transcranial magnetic stimulation, and pallidotomies are some other ways to treat pain. Obviously, with a pallidotomy, we really try to avoid that if at all possible, and that's a last resort treatment. Wearing off, this I think is some of the biggest struggles patients run into, is when their medicine's working, they feel great and life is good. It's when their medicine doesn't work where the problems arise, both motor and non-motor. So I work very hard to prevent this problem, and I think that's where the focus of many of the treatment sessions should be. So we talk about the difference between wearing off and dose failure. So wearing off, it can be predictable or unpredictable. But it's what wearing off is: you take your medicine, you feel better, and then prior to your next dose, you don't feel well from a motor and non-motor perspective, right? With dose failure, you're just not really seeing a lot of benefit, regardless of how or when you take the dose. Both wearing off and dose failure can be predictable or unpredictable, so that doesn't differentiate either one. And this can be a very tough thing to tease out, and sometimes it takes a while for me to tease it out with a patient, maybe a few months or even a year. So some of the treatment options for non-motor: dopamine, right? This whole problem stems from not having enough dopamine. So if we figure out how to optimize the delivery of that dopamine, then initially in the early stages of the disease, that's where you're going to see your most benefit. And then DBS. DBS helps both motor and non-motor, and we've seen this in research studies. What we visually see immediately is, you're shaking with an essential tremor, or you're shaking with a rest tremor, right? I can't really demonstrate that on the computer. And I turn on that DBS and the tremor resolves, or we talk about that stiffness melts away when I turn on the DBS. The rigidity resolves. The non-motor symptoms can be a little bit more subtle and a little bit more difficult to identify, but over years and years of having electricity or neuromodulation to your brain, we definitely see improvements in the non-motor areas as well.
And I just had a question. What specific non-motor symptoms are you seeing improved in DBS?
Hold on. Here we go. So what it's shown is that DBS is safe from a cognitive perspective, right? So we don't feel like it's going to worsen your cognition. There may be a little bit of decline in verbal fluency, but really, quite honestly, we're not seeing that as much in today's world. And I think that has to do a lot with improvement in technology and how the surgeon gets the lead to where it needs to go and positioning of that lead long term. We've seen from a cognition and mood perspective, DBS consistently over time improves depression. And there's a lot of thought behind that. Is that a direct effect or is that an indirect effect, right? Demoralization, right? Problems with your mood because you have the disease, then it's not well treated. Well, if I treat that tremor and I treat that stiffness, the mood inherently is going to improve because you have higher quality of life because you're not so stiff and slow. So sleep. I love this one. We've seen that it decreases nocturnal and early morning dystonia, so your sleep pattern is better because you're not as dystonic. Sleep efficiency improves. And it's very interesting. They did REM sleep studies, and you have better REM sleep when you have a DBS in. And you don't get up and go to the bathroom as much. And you can fight chicken or egg on that one all day, every day, but it doesn't really matter, right? At the end of the day, if you're not getting up 5 times to go to the bathroom at night, well, you're going to sleep better. Who cares where for you as the patient, right? Pain, it improves. And this number to me is just amazing. It goes from 70% to 21% in one study. And I think, again, this is about that dystonia, right? We see a lot of nighttime or early morning dystonia. And if we get that dystonia under control, it is so helpful. There's nothing worse than a painful dystonia. And if you've ever had that, you know exactly what I'm talking about and can be empathetic towards it. This was a 2017 study, and it looked at late-stage Parkinson's disease and advanced Parkinson's disease with deep brain stimulation. And it looked at some specific areas. And so it looked at blood pressure and those patients who had DBS or who did not have DBS. And so if you look at the first line, what we're talking about is patients who were only taking levodopa, right? They had no DBS in them, and their blood pressure decreased after a levodopa dose. If you had a DBS in, your blood pressure did not fluctuate as much. Pain, after somebody took levodopa, their pain didn't improve. But when somebody had a DBS in, their pain did significantly improve. Fatigue, there was no change after a levodopa dose. And remember, this is advanced stage PD, right? The study's talking about advanced stage. So early on, you are going to see an improvement in your fatigue after you take some levodopa, but later on in the disease, you may not so much. Unfortunately, with DBS, it hasn't shown that yet. I think as we become more eloquent with our programming, as we research it more, I'm hopeful that fatigue will also improve. Anxiety, again, there was no change after levodopa, but the anxiety improved with DBS. And again, I think it's interesting here because what's driving that anxiety, just like what's driving the depression, right? Is it the fact that you're having all those motor symptoms that you become anxious? If I had painful dystonia, I would be a nervous wreck, using layman's terms of anxiety, right? So I think it all correlates and ties together. So what are some other ways we can help with non-motor symptoms and motor symptoms and provide a more continuous delivery system? Well, Duopa or levodopa intestinal gel is one way we can do that. It significantly reduces the fluctuations. My approach to Duopa treatment is if we can do neuromodulation or DBS, I want to select that as my number one choice. If you are not a DBS candidate, then I want to move to something like Duopa. I have a patient right now in my clinic who is not a candidate for DBS, and we are actively moving them through the Duopa process to help them with their fluctuations of their symptoms. And going back to the Duopa, they did a non-motor symptom scale score with the Duopa, and all of these things, falls, sleep, mood, cognition, hallucinations, attention, memory, GI issues, sexual function, all of that improved with if we took people who were on regular oral levodopa compared to people who were on Duopa. The Duopa patients did better in all of those non-motor areas. So this is this 2017 study. At week 12, the people who had the Duopa had a significant reduction in their non-motor symptoms. Interestingly enough, if we keep watching those people for more than a year, their non-motor symptoms continued to show improvement. So what's the ideal treatment? Well, we all want to find the cure, right? That's what we're all looking for. So the restorative therapy, the neuroprotective thing, all of that. We've tried all these things, right? The gene-based therapies, the cell-based approaches, nothing's proven yet. I think what we need to find is a way to stop this alpha-synuclein issue, right? That's what we're looking for. So if we can figure out how to stop that neurodegenerative alpha-synuclein issue, that's where we're really going to find the cure. In the meantime, what we've been finding is that BDNF is released when we exercise. BDNF is brain-derived neurotrophic growth factor. BDNF affects change at the cellular level. Thus, it correlates to neuroplasticity, cellular regrowth, and cellular regeneration. You can pull up all of the Parkinson's disease studies and exercise and see that people improve with it. Well, there's some new studies that are coming out that are measuring BDNF, and we're seeing that those BDNF scores are correlating to better UPDRS scores. What does that mean long term? That's still yet to be determined. So what I tell my patients in the meantime is exactly this, right? The serenity prayer. And I think that's the important thing to remember. So I like to end with this. So 10 tips for a common sense approach to life with a chronic illness. And this was published back in 2017. And I always make the joke, and Ines has probably heard this 100 times. This is what I tell my kids right before they leave for school in the morning. Follow directions. Designate a first responder. So who do you call if there's a problem? Be organized. Use trusted sources. Things like PMD Alliance, Parkinson's Foundation, Davis, Finney, all of those, NIH.gov, all of those organizations we know have good quality information. Get the most out of your doctor's appointments. I love some of the little tools that PMD Alliance has put together for things to take to your doctor's appointments. And I just had a patient recently, the past couple weeks, bring me one of those little diaries, and it was so incredibly helpful. So I love that, and that's a great tool to use. Have faith in yourself. Ask for help when you need it. Don't let negative feelings get you down, right? And that can be a tough one. Be adaptable and always laugh. So I hope some of the things I told you guys today are helpful. I have probably 5-10 minutes at the most, Anissa, for questions.
Okay. And I know we're running out of time. So, and I think you covered a lot of that information that they had asked before you got started in your presentation. So I'll go through just a couple. One person wanted to know if there's any correlation between REM sleep, behavior disorder, and dementia.
Yes, there. Yeah.
Okay.
In general terms, yes.
Okay.
It's a complex issue, but yes.
Yeah, the short answer, yes, and it's much deeper than that, I'm
Yes,
sure.
yeah.
And then another person wanted to know when you were talking about, cognitively stimulating yourself each day and reading, they wanted to know, like, looking at print, or do audible books count? And how about reading on the web? Is there any difference between like an audible versus
Yes,
actual reading?
yes, we know that. So, if there is a brain-eye connection, so I like patients to do at least 50% reading. Now, obviously, if you have loss of eyesight and can't do that, something like macular degeneration or something, your cataracts are so severe, then listening is better than nothing. When it comes to reading online versus reading print, my rule with that is much the nighttime issue. I don't want you to be reading on a tablet or a backlit device, whatever that device is. If it has backlighting, there's a ton of research out there about that, about how it's stimulating to the brain and it stimulates those brain pathways. So really getting that backlighting under control and using it, and we're all terrible at it. I'm the worst as well, right? I'm working on my computer till late at night, but it's not the best, right? If we can all eliminate that more and move to the print later in the evening, that will definitely help with the circadian rhythms.
And so, going to the subject of orthostatic hypotension, what is your recommended protocol for home monitoring? Now, this is important for especially those who might be flying solo, living alone. Like, how can they home monitor that?
So if you're a patient in my practice and tell me that you're dizzy and lightheaded, and I evaluate you in clinic, and you have low blood pressure when you stand up, you're going to go home with homework. That homework is, depending on how severe the problem is, 3 to anywhere to 7 days, you're going to monitor your blood pressure at home. You're going to take a blood pressure and a heart rate when you wake up in the morning before you get out of bed. Then you're going to take a blood pressure in sitting about mid-morning, maybe after your breakfast. And then a couple hours after that, so midday, you're going to take another blood pressure after you've been up standing vertical for at least 10 minutes. So whether that's you're doing something around the house and up moving around, you've gone out for a walk, whatever that might be, you're going to take a blood pressure after at least 10 minutes of standing up on your feet with a heart rate. And then we're going to monitor that over time. I don't make big decisions about putting somebody on a medication. I consider medicines to raise your blood pressure strong medicines. So if we're going to use one of those strong medicines, I need good data. So you're going to monitor that at home, and then you're going to give me those results, and we're going to make some decisions. And maybe I'll bring you back to clinic. Maybe we need to do further testing. So we kind of go from there.
Awesome. Well, I know that you have to get back to your clinic, and I really appreciate you taking your time. So for those of you who had questions or more questions regarding neurogenic orthostatic hypotension, we do have a program coming up in the future specifically on that topic. We also have one coming up soon on pain, and they are going to cover dystonic pain. So I know there was a few more questions about dystonic pain that we didn't get to, so we will be able to cover those in another segment. And I know I've had some feedback from people that they want to be able to save the chat before we close out. So I just want to highlight, in case you want any comments or you want to save the chat, how you can do it before we sign off. If you go to your chat box where you would type a question, you'll see a little smiley face and then 3 dots. And if you click that 3 dots, it'll pop up a little box. And at the very top, it says save chat. If you do that, it'll save the chat to your computer. So I'll give you a minute so that you can do that. In the meantime, I want to thank you, Dr. Bolin, so much for joining us today and giving this great overview. I love that you added that whole mindfulness part in there. It's very important. And somebody did add to that. You mentioned your one resource, and someone mentioned Insight Timer. I actually use that, and it's a really good one. And another question is, and we didn't get a chance to address it, but if you're willing to share the slides, and you can let me know, and then we can add those later to the recording, which will be up by the beginning of next week for everyone. So I want to, and I'm going to stop sharing your screen so that we can all see you and you can see us, so that we can thank you, give you the wave of gratitude, send you off for your weekend in a positive way. Happy Friday. Good weekend to you. Thank you so much. Happy Friday and good weekend to everybody joining us today. It's so good seeing you. We will see you again next week. Thank you, Dr. Bolin.
Bye. Have a good weekend, everyone.
Bye.